So, welcome back. Welcome back to part 2 of headaches in long COVID. I'm Dr. Tim Robinson, formerly a family doctor for 30 years, and now a long COVID services doctor for 5 years. So, I post on podcast channels and YouTube. I hope you find them helpful. If you'd like them, click subscribe. I have to add my usual disclaimer, of course. Any advice or treatment I mention should only be considered after discussing with your own doctor. So, in part 1, what did I talk about? I talked about what patients are experiencing, the symptoms, and what we do about it, off to the GP, to get the diagnosis, make sure we're not COVID blind. And I then talked about causes, and I think you'll agree there were quite a few causes, both sort of directly and indirectly: inflammation and dysautonomia and the mast cells and central sensitization and not forgetting tension headaches and also overuse of paracetamol. Beware, but certainly tension headaches as a result of, feeling tense, which, there's a lot of tension about, stress and tension. So, when I talked about, what are patients experiencing, I talked about the different types of headache. I talked about the skull cap headache, the band, the tension headache I've just been talking about, the neck, one-sided, both sides. I talked about both new onset headaches. Patients are saying, I never had headaches before. I've never been a headachy person. But since I've got long COVID, it's just one of the many symptoms I now have since having COVID and with my long COVID. But also I've got the other group of patients who have had migraine in the past and control it nicely with their meds, or it's not happening very often. And so happy with that, but since having COVID, long COVID, migraine has really got totally out of control. And consequently, headache, it's a very common symptom in long COVID. And let's face it, anyone with a headache, who's had a headache, knows about headaches, it does make an impact on your life and a significant and often severe effect on your quality of life. Like I said, it's off to the GP so we can get the diagnosis and be sure that we are dealing with long COVID headache. So, what are we going to do about it? How are we going to tackle this? Okay, well, I thought what we'd do first is, if you like, start with migraine, because it's really quite neat. It's a diagnosis. And we've been aware of it for, hundreds of years. And we've got quite a good package of treatment for it. But I think the thing that comes home to me, having heard so many long COVID stories over these 5 years, is the number of patients whose migraine has got way out of hand and they're really suffering, but they've not, and they're still struggling on with their previous migraine treatment, and it's not helping. So please listen to this. It's time to go to the doctor and ask your GP, can we do something different, or can we modify our migraine treatment in some way? So migraine, it comes in sort of, if you like, the actually acute form and the chronic form. So acute is the sort of once in a while migraine attack. So, say once every few weeks, or once a month, once every couple of months. Often women who are menstruating do find that migraine can come with the premenstrual phase of their cycle. So, infrequent, really what I'm talking about. And so if it's infrequent, then, most people would be, they can just ask the doctor or go to the chemist and buy themselves some sumatriptan tablet to take at the onset. And that's the important thing, is to take it as soon as you get the aura, the premonition that you are going to develop a migraine. So take a sumatriptan, 50 milligrams. If, however, your migraines are coming more frequently than that, in a way it falls into the chronic migraine situation. And if you're having more than one a week, really you should be on prophylactic treatment. And, basically migraines can last sort of many hours, can last more a couple of days. And so if you're having them once a week, then that can knock out 3-4 days per week. So clearly that's too often. So therefore we've got to try and prevent those migraines in the first place. Stop them coming. Got to give you prophylactic treatment. Prophylactic treatment. Well, the drug that we use more often than not, and because it's really effective, is amitriptyline. Amitriptyline actually is in the class of tricyclic antidepressants. So it was the first antidepressant that was synthesized, created, manufactured. But this was like 50, 60 years ago, probably 70 years ago. But the thing is, we don't use it at all for depression anymore because of side effects. Can cause dry mouth, but worse, cause sedation. Okay. So no GPs use migraine. Use amitriptyline for depression anymore. Plus, also we have some amazing antidepressants these days. The SSRIs, selective serotonin reuptake inhibitors, are so much better, so much cleaner, and so much more effective than good old amitriptyline. But amitriptyline, we know, is actually quite good, very good, for neuropathic pain. So pain that is sort of has a neurological element to it. Okay, so we use it as a migraine preventer, and it's good also because of its sedating effect. It's quite good as a sleep enhancer as well. And indeed, instead of giving patients what's known as Z drugs, addictive benzodiazepine, the zopiclones of this world, sleeping tablets, GPs will give amitriptyline at a 10 milligram dose. So that is the dose to start with for migraine prevention, 10 milligrams at night. And after 2 to 3 weeks, you will notice that your frequency of migraines, severity, duration, all tail off, if not prevent them altogether. Plus, you have a good night's sleep. It's good. So that's the one that we try. Sometimes you need to increase it to 20 milligrams, 30, 40, can go up to 50. But actually, majority of patients cope with 10 or 20. That's good. Higher doses can make you feel a bit dopey the next day, a bit of a hangover effect. So we try not to go higher dose, but 10, 20 is usually enough. Like I said, this was the first antidepressant. So look, please take this on board. If the GP prescribes you amitriptyline and you look at the instructions in the box and it says antidepressant, don't think that the GP is giving it to you because he thinks you're depressed. No, it's because of these other properties that I'm talking about. It's usage these days. It's nothing to do with depression. So don't sort of like say, I'm not taking that because he thinks I'm depressed and I'm not depressed. And you're not depressed, and actually you're not taking it for the wrong reason. You're not taking it because you think he's labelled you depressed. No, you're not. You should take it for amitriptyline for its migraine preventer properties, which is good. Now look, if the amitriptyline doesn't doesn't come up with the goods and it's not preventing your migraine, then there are a couple of other medications that the GP can try. Topiramate is the next on the list. And in NICE guidelines, the NICE National Institution of Clinical and Health Excellence, NICE guidelines puts that next on the list, and then one after that is candesartan. So topiramate is an anti-epileptic drug, 25 milligrams at night. It can cause a bit of sedation as well. It's not a bad thing, but that's a drug that's certainly approved, and that's, if you like, second line. Candesartan is an anti-blood pressure drug. It's used in heart failure as well, but that's not why the GP is giving it to you. GP is giving it to prevent your migraine. Okay, 2 milligrams is a minuscule dose. 4 milligrams is the usual dose that we use for blood pressure, say, and up higher, but 2 milligrams safe as houses. And both of these have been around for probably 20 years, I guess. In the old days, migraine prevention, a lot of GPs or neurologists would recommend the use of a beta blocker. So propranolol was the one that was mostly chosen. It's a non-selective, non-cardioselective beta blocker, which is effective. Okay. Not, I hasten to add, not as effective as the other ones I've just mentioned, but it is effective. However, it comes at a price. It's because it's got a few side effects which are a bit unfortunate, especially in the long COVID context. It can make patients do complain of heavy legs, and they can feel, because it has an effect on the blood vessels going to the legs. We don't give it to patients with something called intermittent claudication, so narrowing of the arteries, feeding the calves. So it gives you heavy legs, but also can make you feel sort of slightly fatigue and muscle fatigue. The other thing that, being non-cardioselective, it's actually more likely to trigger asthma. So we tend not to give it to patients with asthma. But anyway, that's an aside. It's not, in my experience, as good, as effective as the other ones I mentioned. Plus it comes with its own side effects, and some of those side effects coincide with long COVID. So your fatigue of long COVID could be made even worse with propranolol. Not what you want. So those are the sort of, like I said at the start, this is what we do for migraine, okay? Because it's tried and tested, and over a long period of time, all these drugs. I also would say that, and again, I always recommend that those patients who don't have migraine but who have new onset headaches, long COVID headaches, it's logical to try the same treatments, okay? Even though it's not, it's not your classic barn door migraine diagnosis. There's no harm in trying those medications that I've mentioned for migraine for new onset headaches. Those patients who say, no, I had a headache before, and I've got this now sort of neurologically type headache. Try it. What else can we try? So, okay, well, there are a couple of others, and they're more in the supplements range, if you like. When we think about migraine, and when I talk about migraine, I'm actually sort of including the new onset headaches as well. But the research on migraine and what we understand about migraine is that it's a very complicated condition that has probably many facets in it. Again, sounds a bit like long COVID, doesn't it? Many facets. So there's an inflammatory component to it that leads to migraine. There's an excessive oxidative stress, so the sort of free radicals in patients with breakdown products of metabolism in patients with migraine. And also in patients with migraine, there's what's been found is what was known as mitochondrial dysfunction. So poorly functioning mitochondria. Mitochondria being those energy factories within every cell of the body, okay? Ranging between about 500 to 1,000. Brain and heart have, way up top end, around about the 1,000 mitochondria per cell, whereas, other tissues, tissues anywhere will have less mitochondria. It all comes down to how much energy those cells need, and both brain and heart muscle are high energy expenders. They need lots of energy production. So migraine, it has been found that in migraine, the mitochondria don't work so well. So therefore, we want to try and combat those three factors: the inflammation, we want to combat oxidative stress, and we want to basically feed the mitochondria. We want to stimulate the mitochondria in order to make more energy. There are three supplements that can actually help us. One is riboflavin. This is vitamin B2, which we get from our diet. Okay, so a mixed balanced diet will provide you with vitamin B2. And vitamin B2 is an anti-inflammatory agent, has anti-inflammatory properties. It reduces oxidative stress. Okay, it mops up those free radicals, those destructive byproducts of metabolism. So it reduces the oxidative stress, it reduces the free radicals, but also it supports mitochondrial function. Okay, so mitochondria work better with vitamin B2. You can get this over the counter in your health food store. So you should be taking 100 milligrams a day. Riboflavin is actually listed as one of the other medications. I was going to say medications. All right, supplements are other things, measures you can take to actually help your migraine as a migraine preventer. So it's in the NICE guidelines, National Institute of Clinical and Health Excellence. It's there. And they say you should be taking, for preventative migraine prevention, 400 milligrams a day. So 1 tablet a day. Okay. So if NICE say it's okay, it's worth trying, isn't it? And I've given you reasons why it may be helpful for you, those anti-inflammatory properties, etc., etc. One thing for you to note, though, actually, this is a weird one. One of the side effects, everything has side effects, but it's actually pretty clean. It doesn't have, too many problematic side effects. But one of them, slightly bizarrely, is that it makes your urine, your pee, turn bright yellow. So don't get a shock. If you're on your riboflavin and your pee is bright yellow, just chuckle to yourself. It's my vitamin B2 going down the loo. There we are. So there we are. That's the first. So riboflavin, done. Magnesium is the next one. Again, this has been well researched. So magnesium is a element, isn't it? And we get this from our diet. Magnesium is the heart of chlorophyll. It's the iron in chlorophyll. Chlorophyll is green, okay? The green in our leaves, okay? So the reason why the leaves are green is because of the magnesium with the rings, the biochemical rings around it that does what it does. So it's naturally occurring, but and we all need it for lots of functions in our body, not only bone laying down, etc., but muscle function, but lots of nerve function. And it has been found to reduce the pain chemical called substance P. It reduces the release of that in the brain. We know that as a fact. We've seen this in the lab. It also reduces vasoconstriction in the blood vessels in the brain. So I talked about these blood vessels and the diameter of the blood vessels, either really wide, dilated, or constricted. One of the mechanisms in migraine, in the migrainous process, an acute migraine, is clamping down of those blood vessels, the cerebral blood vessels, okay, in your brain. So magnesium reduces that dampening down. So therefore, it gets to the heart of the problem behind underlying migraine. So those are the reasons why it could well work, okay? And there are studies to show it does work. So again, off to the health food shop, store, get yourself some magnesium. Now, a word of warning though. Magnesium comes in all sorts of salts. So magnesium oxide, magnesium sulfate, magnesium glycinate, magnesium citrate, lots of different salts. The cheapest is magnesium oxide. Okay, so therefore the drug companies and health food shops probably are going to be making the most money of it. So don't be pushed into getting yourself some magnesium oxide. And the reason I say that is because the common symptom of magnesium oxide is diarrhea and colicky pains and wind and bloating. Okay, in long COVID, that's quite common. Those symptoms are quite common in long COVID. You ought to see or listen to my podcast or YouTube on gut problems in long COVID. So, you don't want to take magnesium oxide because it'll make those other long COVID symptoms worse. No. Instead, you ought to take magnesium glycinate. Okay. It is better. It doesn't have those gut side effects, but also it's found to be calming, reducing in anxiety, and also sleep enhancing. Those are 3 good reasons to take it. Anyway, but in our long COVID world, low COVID symptom complex, it's nice to be calm, not worried, and sleeping well. We know that sleep problems are a problem in long COVID. So 200 to 400 milligrams. I'm being conservative here. Some people say 600, but basically 200 to 400 at night. Yeah. So make sure the message is get yourself magnesium glycinate. Okay. Not oxide. Okay. Citrate is quite good. Magnesium citrate is quite good, but it does have some of those diarrhea and crampy symptoms too. Stick to glycinate. Yes. So riboflavin done, magnesium done. Last one, coenzyme Q10. CoQ10, you might know it as. You might have heard of it. CoQ10 is an antioxidant, okay, that reduces oxidative stress. So like riboflavin, so it's an antioxidant. It mops up those free radicals. CoQ10 is also a transporter on what's known as the ETC, electron transport chain. So it's part of that chain. It's naturally occurring in us all, something called ubiquinol. It is part of that ETC, the electron transport chain, whose function is, you might have heard of as a TCA cycle or the Krebs cycle. It is the energy production cycle. Okay, it makes ATP, adenosine triphosphate. It's the thing that gives you energy, your energy currency to do all its functions in the body. Okay, so it's part of that cycle. So therefore, the logic behind it is if you can add to that cycle, then you're going to improve energy, but that in turn has been found to be good for migraine. And I must say that all 3 of those are backed up by positive studies that that are evidence-based studies, double-blind, placebo-controlled trials. Okay, some of them are stronger than others, evidence-wise, but they're all positive, and I will only give you those trials that are backed up by that are backed, research-based, etc. So all of those things are worth trying. Some people say, I'm going to have them all. Well, you could do that. However, I'm always a bit wary of rushing in and taking the stack of supplements and pills and what have you. Always quite wary of that. Try one at a time. So, start at the top, B2. See if that takes your migraines away. If it does, there's no need to add in magnesium, CoQ10. No, because B12's done the biz. So, there we are. Or if it doesn't do the business, then try magnesium instead. Run it for 3-4 weeks. Better, worse, or exactly the same? Am I better? Worse? Exactly the same? Are my migraines better? Worse? Or exactly the same? Well, if they're better, you're just going to stick with that, whatever you tried. If they're worse, you're going to chuck it out the window. And if they're exactly the same, actually, it's not really make a difference, is it? Okay, so you're probably going to chuck it out the window as well. Go to the next one. So that's my approach. But, as long as it's those doses that I've recommended, but also, check what's on the box, what's on the label. Make sure you don't exceed. Don't be greedy. Don't be impatient. Make sure you stick within the safe limits. So there we are. Those are the treatments that I would suggest for headaches and migraines. New onset headaches or migraines that have got out of control. So what have I talked about? I've talked about basically my summing up, if you like, is, safety first. Any new problem, report it to your doctor, please. Let's be safe. Let's not be COVID blind. It might have happened at the same time as COVID, but let's just make sure there's nothing else. There's nothing more sinister. I then covered the causes, and like I said, it's so important to understand all the causes, understand the problem. It brings us validation, it brings us acceptance, both really important. And then I covered the meds, the drugs I would suggest, and the supplements I would suggest. But this is in a way I've focused really on migraine, but it's all part of the package. We've got to think of long COVID recovery overall, don't we? We've got to, keep remembering those other things we advise, those other strategies, for your fatigue and your brain fog. Think of the 3 Ps, the planning, the prioritizing, and the pacing. And think of gentle reconditioning of the body with sort of the muscles stretching and the ligaments stretching, getting more suppleness and sort of waking the muscles up, if you like. Take on yoga, why not? It gives you focus, and talking of focus, but also stretching and all the rest, and breathing. But it's also, thinking focus, thinking mindfulness, that mindful meditation, focusing on the now. Okay, not worrying about the past, not worrying about the future, just focusing on now, being thankful for now. And both mindfulness and yoga are backed up by lots of studies. We know this, and lots of studies. Mindfulness has in excess of 1,000 studies that prove that it makes a difference, both in physical and mental, and the interaction of the two, and the immune system. So give it a thought, mindfulness. That's funny, because you shouldn't really be thinking when you're doing mindfulness. You should be focusing on one thing only. However, there we are. Mindfulness, give it a thought. And the other factor, of course, is sleep hygiene. Remember, sleep disturbance in long COVID is such a common symptom. Do a podcast on that. So remember sleep hygiene. Remember, maybe Piriton or melatonin for that. So what I'm really talking about is the whole package. It's not just focusing on the drugs for your headaches, etc. But along with everything else, the full package for recovery from long COVID. And basically, and just remembering that natural healing is all part and parcel of this. And natural healing takes time. I've talked about studies that show that there are these changes in the body, in the tissues, in the brain, in the nerves and the blood vessels, etc. There's something being damaged, inflicted, and you're bearing a scar at the moment, if you like. And it takes time for natural healing to occur, natural healing and repair and rebalancing, etc. And in the brain, this sort of reconnecting and rewiring, this process of neuroplasticity, it takes time. They say anything up 2 to 3 years for reconnection of nerves. Okay, it seems a long time, and it is a long time, but it happens. It takes time. Inflammation takes time to quieten down. It does quieten down with time, as long as you employ the package of everything I've talked about. So it takes time in the brain, when focusing on a headache, long COVID talk, the microglial, the brain's immune tissues, the brain's defense, immune lymphatic defense, takes time to quieten down, takes time for those mast cells to stop being so active and stop and releasing their components. It takes time for those mini blood vessels to clear those microclots or new blood vessels to be created. It all takes time. And it's important for thinking, to encourage a sort of the mind-body connection, to be calm and understanding and acceptance. All that helps with the recovery from your long COVID. And in this case, from your long COVID headaches. So there we are. That's the update on headaches in long COVID. I hope you found it helpful. As I said at the start, this is an educational series for you long COVID sufferers. But remember, my usual disclaimer, any advice or treatments I've mentioned, discuss with your doctor. Remember, safety first. If you found this helpful, click subscribe. Sorry, it's a bit of a cliche now. Everyone does it, don't they? Everyone says it. But the reason I'm saying it is actually it helps to get it out there, spread the word, to help more people. And that is my mission statement, to help as many people as possible for long COVID recovery. Spread the word. So thanks for the feedback. Again, I said this at the start, didn't I? Look, I'm so sorry. I just haven't got time to respond to all your comments and suggestions and personal sort of identifying with what I've been saying, etc. But I do appreciate, I read them, and it helps me with my future posts. So, there we are. That's it. So watch out for the next one. So in the meantime, I wish you well in your recovery, in your long COVID recovery. So I would say all the very, very, very best to you now. All the very best.